Hello, student. How are you? I think you are all are fine and hearing me. Last lecture discussed with neonatal intestinal obstruction. I think both of 21st and 22nd batch you are present here. And on my last lecture, I was discussed about neonatal physiology and some anatomy and the criteria of or classification of low birth weight infants. Also, some physiological abnormality in like anemia, jaundice, and thermoregulation. How to regulate temperature, unit, and how to balance fluid and electrolytes. So these are very sophisticated and very carefully managed. Some congenital anomalies are here. Some common surgical congenital anomalies are concerned with nervous system, that is meningocele, myelomeningocele, encephalocele, hydrocephalus, and uh, more important about gastrointestinal tract. Some obstruction, neonatal intestinal obstruction, where I listed that is anorectal malformation, Hirschsprung's disease, neonatal intestinal perforation, neonatal enterocolitis, Meconium ileus, volvulus neonatorum, malrotation of gut, duplication of gut, intestinal atresia, omphalocele, gastroschisis, and umbilical hernia. That is about abdominal wall defect. And some other concerned with infantile intestinal obstruction in infant age. It is infantile hypertrophic pyloric stenosis, intussusception, congenital bands and adhesion. So these are related with gastrointestinal tract. Some are hepatobiliary system, that is choledochal cyst and biliary atresia. And among the genitourinary system, exostrophy of bladder, congenital hernia hydrocele, undescended testis, hypospadias, epispadias, phimosis, paraphimosis, Wilms tumor, PUJ obstruction, and posterior urethral valve. And some facial deformity like congenital cleft and palate, and limb deformity, congenital club. So these are some common surgical congenital anomalies in neonates and infants. Today I will discuss about intestinal obstruction. Now, what is intestinal obstruction? So, in a word, a mechanical blockage arising from a structural abnormality that present a physical barrier to the progression of gut content. And in shortly, you can say arrest of downward propulsion of intestinal content. This is intestinal obstruction. Some are partial or complete, and some simple or strangulated. What is ileus? Is a paralytic or functional variety of obstruction. This is a functional variety of obstruction. So, according to speed of onset, it is determined whether the obstruction is acute, chronic, or acute on chronic, which I have discussed earlier in my last lecture. There are some pictures showing congenital anomalies uh, related with intestinal gut. It is gut related. This is myelomeningocele. It is a swelling over the lumbosacral region. This picture shows imperforated anus, that is anorectal malformation. There is no aperture in the perineum. And also a neonate showing a lumbosacral swelling, which is suggested, diagnosed as a case of myelomeningocele or meningocele. So these are some image. There are also some images of congenital anomalies. Here is congenital diaphragmatic hernia operated and also imperforated anus. These are others. And today I will discuss about intestinal atresia. Uh, I hope you all have gone through this intestinal atresia in your book. And on my last lecture, I was discussed about obstruction. That is, what is atresia? A means absent, tract, atresia. That is absent of intestinal lumen. You know the luminal continuity is must for proper physiological function and anatomy for intestine, which is extend from mouth to anus. Anywhere, if there is no lumen created or in intrauterine life, if it is erased, the luminal continuity is affected, and intestinal atresia occur. So this is congenital partial or complete absence of canalization or patency of intestinal lumen. Is called atresia. And it gives rise to intestinal obstruction very early age, that is in neonate. Patient may complain about vomiting, intestinal abdominal distension, upper abdominal distension chiefly. Stomach, duodenum will be distended, and uh, there will be squeezed and narrowed intestinal component distal to the atretic segment. So there are some atresia here. That is, it may occur in anywhere in the gut, chiefly in the duodenal portion, duodenal atresia, maybe in the ileal, maybe in the jejunal, maybe in the colonic and rectal. It may occur in the esophagus also, and when it is called esophageal atresia. And this esophageal atresia may be related with or associated with a fistula with trachea. That is esophageal atresia with tracheal fistula. Uh, and sometimes there will be no fistula with trachea. In that case, only esophageal atresia may be found. In case of it is esophageal atresia, neonate will uh, present to with you very early age or in after 0 day or 1 day after birth. That is, the baby is not swallowing, frothing, and coughing, and frothy discharge through the mouth, and also sometimes respiratory infection, respiratory difficulties. So these are the some symptoms and signs of esophageal atresia. You can evaluate this esophageal atresia by giving a nasogastric catheter or nasogastric tube. If tube is not uh, easily passed through the esophagus into the stomach, then you can say or you can guess that it is esophageal atresia. And also some types of contrast X-ray can reveal esophageal atresia, duodenal atresia, and all other types of GIT atresia. So, in our concern today is duodenal atresia and jejunoileal atresia, and very rare colonic and rectal atresia. So what are the types? That is partial atresia. It is present a wave or diaphragm or membrane that partially occlude the lumen of intestine. When there is a wave or diaphragm present in the within the lumen, which created an obstruction from the proximal to distal direction, there may be a little opening in the diaphragm, which may allow some of fluid through this portion and may create a partial obstruction. But when babies grow out and taking adequate, taking huge amount of milk or liquid, then baby will come to you with some obstructive features. So these kinds of baby with partial obstruction may present to you uh, sometimes or some after 1 month or 2 months after birth. But in complete types of atresia, when completely obstruct the lumen due to absence of a part of segment of intestine, these types of baby will come very early because of continuous intermittent vomiting after taking food. So it is called uh, complete atresia. Now I will show you some picture for your better understanding. Here, this is a distal segment. This is distal segment, intestinal segment, which is dilated. You can see dilated segment followed by narrowed segment. And here there is no continuity of the lumen. This is, and maybe there is a wave or diaphragm within this dilated and squeezed or narrowed segment. And this diaphragm may obstruct the content from the proximal to the distal direction. So it may little bit uh, develop intestinal obstruction, partial intestinal obstruction. And it is called type 1 intestinal atresia. Now, complete intestinal obstruction. So this is there is no a gap between the two segment of intestine. One is dilated proximal loops, and another is constricted and narrow distal loop. And there is no any intestinal segment or fibrotic, and there is a fibrotic elements between these two segment of intestine here, but no canalization. This is called complete intestinal obstruction. It is, and it is also type 2 complete intestinal obstruction. This is another type. Here there is no any fibrotic scar, fibrotic elements, fibrous tissue, or any other components to breeze two segments of intestine. One is dilated segment and another is constricted segment. And there is a B-shaped mesenteric gap you can see, and there is no blood vessels here, and no segment uh, developed at all in the in between these two segment, and it is called complete. That is type 3 or type 3A, type 3B also here. It is multiple segment atresia, also called type D. It's very uh, vulnerable to uh, preterm or premature infant, premature neonate. All these things are common in premature uh, baby. That's in intrauterine life. There may be hazards. There may be ischemic insult within the GIT system, and this ischemic insult may develop some segment is not properly uh, canalized or properly developed. So this may create a problem in passage of intestinal content from proximal to distal. Here you can see some multiple segment atresia is another very vulnerable to case of preterm no birth weight babies. And what are the presenting feature? Now about intestinal obstruction, presenting feature is common to all. Age to age, it is not varied. But in case of neonate, it's sometimes some extra features are here. That is, abdominal is distension, it is common. Vomiting also common, and associated some features, that is feeding intolerance. Baby will not take food enough and always in crying. Failure to thrive, dehydration also is also uh, very common due to failure take enough milk, breastfeed. Also, septicemia is also very common for neonate because of immunosuppression, respiratory tract infection, anemia, jaundice, and associated other congenital anomalies are also found in case of the babies with intestinal obstruction due to intestinal atresia. You can see or you know that the one congenital anomalies, if there is one congenital anomalies, you can search for other congenital anomalies whether it is present or not, because one congenital anomalies may gives rise to other congenital anomalies in different types of system. So this is a picture showing atresia. A means atresis, no. A means no, or without orifice. Atresis means orifice. That is, no orifices, no canalization, no luminal development. Uh, Earlier, I have mentioned about these, that is esophageal atresia, and here this is trachea. Esophageal atresia also merge with tracheal wall, that is it presented with esophageal atresia, tracheoesophageal fistula, tracheo tracheoesophageal fistula. There may be fistula, there may be not fistula. So this is the proximal end of the esophagus, and there is no segment here, and also the distal segment is begins and forming a fistula with trachea. So this is called esophageal atresia with tracheoesophageal fistula. Sometimes esophageal atresia with or without tracheoesophageal fistula. So if there is any frothy discharge through the mouth, through the nose, continuous cough, and not tolerate food, and after uh, nasogastric feeding insertion, if feeding tube is stopped here, Feeding tube is not negotiated to the distal portion of the esophagus through the stomach, and it is obstructed here. Feeding tube is not further not passed through the distal portion. Then you can easily diagnose that is it is esophageal atresia. And confirmatory diagnosis is just allow some barium or iopamero water soluble contrast through the esophagus and take an X-ray. And you can show the contrast will accumulate here, not passed through the distal end. It is very difficult to manage. Sometimes it may need to thoracotomy and also fistulectomy and end-to-end anastomosis by keeping a nasogastric tube through the anastomotic site. Need NICU coverage. So this is also a atresia, atretic segment in the duodenum, and the second part or third part of the duodenum is atretic. There is no any communication between the proximal and distal gut, so it is called duodenal atresia. So incidence of duodenal atresia is 1 in 5,000 to 10,000 live birth, and jejunal atresia is 1 in 5,000 live birth, and colon atresia is about 20,000 live birth. So it is seen that duodenal atresia and jejunal atresia is more common among these types. So what are the etiology? Etiology is exactly not known. It is unknown, but various theories are offered. That is failure to recanalization. Why this is intrauterine vascular accident. I mentioned earlier that is any ischemic insult to the intrauterine vascular portion, and the vascularity is losses, followed by a segment of intestine is lost, and there is no communication between the two segment. This is called intrauterine vascular accidents. Some vasoconstrictor drugs, when it is used maternal in intrauterine life, some vasoconstrictor drugs may create or develop constriction of the vessels and the free circulation or easy circulation of the blood may hamper to the vessels, and this may give rise to ischemia to the part of the intestine, and also this intestine may necrosed or lost in intrauterine life and creating a problem like intestinal atresia. Summer maternal infection and familial cause is also important. Every congenital anomalies or disease, you can you should take history about family. That is, any other child or any other family member was suffered by these types of anomalies or not. This is a picture showing vascular accident during intrauterine life, that is creating intestinal intestinal atresia. Here it is seen that some portion it is developed, but sometimes due to some vascular hazards or vascular insult, some portion may be ischemic or necrosed and lost, and may create a gap in the uh, intestine, gap in the intestine. So this is called intestinal atresia. Jejuno-ileal atresia. Lecture, Niram, lecture. Jejunal atresia is also a common. It is duodenal atresia is also common in jejunal atresia. Most of the I have shown you the incidence. That is, incidence is more or less same about duodenal and jejunal atresia. So these are some uh, pictures showing jejunal atresia. This is same I have show you earlier. This is another example, or this is another types, another images showing a diaphragm or wave within the lumen of intestine, which may also create obstruction, continuity, loss of continuity. And every time, remember this uh, the proximal end of atretic segment will be dilated and the distal segment remain constricted or squeezed or narrow. So these are some types. These are sometimes multiple atresia. So clinical features: failure to pass meconium, abdominal distension, and vomiting. The early presenting features about in case of intestinal atresia. What is failure to pass meconium? So this is important about neonatal evaluation. It is failure to pass meconium since birth. Since birth, the baby has to pass meconium after birth immediately within 6 hours, 12 hours, and maybe 24 hours. But in case of not passing meconium after 24 hours, 36 hours, or 48 hours, this is significant. History is significant. So must evaluate failure to pass meconium at first, and abdominal distension, of course, and vomiting is the main clinical features. There is others. Some are prematurity, low birth weight, dehydration, decreased urine output. These are associated features may be found. So how can you diagnose the atresia? That is prenatal ultrasonography may show polyhydramnios. Plain X-ray abdomen may show the gaze shadow, indifferent or mm, pathological gaze shadow in the plain X-ray abdomen, which may be one or two gaze shadow with fluid level. And contrast X-ray of gastrointestinal tract is also important, but we avoid or sometimes contrast X-ray of GIT neonate because it may gives rise to some aspiration leading to pneumonia. So better to avoid contrast X-ray in case of neonate. Plain X-ray abdomen can be diagnostic, and also clinical history is also important. These are some skiagram or X-ray shows double bubble gaze shadow here, stomach gaze shadow, fluid, and also in the duodenum. So there is hourglass appearance of rest of the abdomen, and that is no intestinal contents or no intestinal gaseous contents here. That's why no intestine are visible the late part of the X-ray film. So this is diagnostic for duodenal atresia. That is double bubble gas shadow. If there is multiple bubble gas shadow, it is jejunal atresia. If it is double bubble, it is confirmed that is duodenal atresia. And there is some multiple bubble schedule here. Uh, reflects jejunal attrition. This is contrast enema or contrast extra of the gut, GIT. Here you can see the contrast is not passed through this duodenal, not beyond the duodenal cap, the first part of duodenum, up to the first part of duodenum, and there is no dye passed through this portion beyond the first part of the duodenum. So it is diagnosed that it is a complete obstruction or complete atresia of the duodenum. Here some dyes pass through the narrow segment of the distal gut. I think, barium or contrast enema X-ray. It is contrast wheel X-ray. So how can you manage these types of baby, these types of DNA? First, you can see that, or every types of intestinal obstruction can uh, should be managed by nothing parallel gastric suction, IV fluid. It's important to uh, correct dehydration, correct electrolyte balance, and also IV antibiotics, as there may be uh, endotoxin release and endotoxic shock may be present, and it may be uh, protect by giving IV antibiotics, or also injection vitamin K in case of neonate, premature neonate. Vitamin K is important because liver immaturity. Glycerin suppository or glycap suppository, rectal suppository is not recommended for completed shear, complete intestinal obstruction or acute intestinal obstruction. It may be recommended sometimes in case of chronic or subacute intestinal obstruction. And also catheterization is important to maintain the urine output measurement. What may be the complication? Perioperative, early postoperative, late postoperative. So the treatment is, definitive treatment is surgical. Uh, uh, Surgically or laparotomy, you can uh, assess or go through operative technique. So some complication may occur in perioperative, early postoperative, late postoperative. So what will be the management, surgical management? Surgical management is nothing but anastomosis. It's called anastomosis, end-to-end anastomosis. So our uh, important sign is the proximal dilated segment and also the distal squeezed or narrow segment. Our target is to create a channel or create luminal continuity. You can do that by end-to-end anastomosis of the proximal and distal guard. So here is the problem is created here. That is, this is very large, very elongated, large guard, proximal guard, due to accumulation of fluid uh, and also contents, intestinal contents, and also air accumulated here, and gradually the distension occurs. So the more distension occur comparatively compared to the distal segment. So it is challenging to create an anastomosis between these two segments because this segment is very big and dilated. So you may puckered the intestine by stitching the wall of the intestine and can, mm, can create a lumen like this, and you can easily anastomose at that time. So the puckering of intestinal lumen is one method. Also, when you dissect the lumen, you can uh, close some portion of the lumen and end-to-end anastomosis the rest of the portion. This is the another portion. So surgeon will decide what should be done perioperatively. So our goal is to create, or our plan, or our mm, goal is to create the intestinal continuity as baby can baby can transmit, or intestine can transmit. Free transmission may be occur, should be occur through the intestine. Every time the you should or after operation or post operative, the anastomotic leakage should be prevented, and anastomotic leakage should be prevented by giving proper uh, anastomosis anastomosis of the two segments well, and very carefully, and using a mm, very small uh, special brickle made brickle. It is you can use 40 brickle round bodied for anastomosis the two segment. So carefully anastomosis and anastomosed the segment can give you the better result postoperatively. So these are the uh, actual surgical management of intestinal atresia. And after operation, there should be follow up early postoperative. You can evaluate, or you can check the incisional wound area, third or fourth or fifth, third or fourth POD, postoperative day. It is whether any infection or not. You can evaluate. You can search for bowel sound appeared or not, and we uh, usually give per oral after fifth postoperative day. In late postoperative, sometimes baby may come to you with some obstructive features due to stricture of the segment anastomosed. Now, today, uh, some discussion with anorectal malformation. I will discuss it today because we have enough time to give some uh, discussion about anorectal malformation. What is anorectal malformation? No, anus and rectum. There may be malformation occurs. So this is called anorectal malformation. It is represent a spectrum of congenital abnormalities where the anus fails to open normally onto the perineum. The anus is not open into the perineum. If there is no anus in the perineum, there may be not a failure to pass meconium, which I have earlier mentioned to you. That is, meconium passing is history of meconium passing is very important. You should take history at first. If any patient and any baby come to you, mother with parents that may complain that my baby is not passing meconium yet after 24 hours or 36, 48 hours after birth. So you must go for search about anus, whether the anus is uh, situated or located perfectly, appropriately in the perineum, or there is not or absent of anus, not any uh, aperture in the perineum. This is called imperforated anus previously, but nowadays the imperforated anus is not using by pediatric surgeon because there may be another malformation like rectourethral or rectovesical fistula. The rectum is not failed to open downwards in the anus. Rather, it may open into the urethra or urinary bladder, which is the immediate anterior relation uh, with rectum. So there may be anorectal fistula, rectourethral fistula, or rectovesical fistula associated with imperforated anus. And that's why it is called nowadays it is anorectal malformation. It occurs in approximately 1 in 5,000 live births, so incidence is not so uh, less. And some associated anomalies and the defect may occur as part of a syndrome such as there may be anomalies like vertebral, anorectal, cardiac anomalies, tracheoesophageal, renal. And you should search all the parts of the body, others like vertebra, cardiac status, tracheoesophageal esophageal status, kidney, and also limb status. There may be defect with anorectal malformation. So embryologically, anorectal malformation may be due to arrest of division of cloaca by mesenchymal growth and may occur at any stage of developmental process leading to a wide variety of anorectal malformation. So you know about the cloaca, the downward or the most dependent or distal part of the gut, and from which rectum is rectum and anal canal is developed. So any abnormal division of cloaca occurs in intrauterine life. It may give rise to developmental anomalies like anorectal malformations. This is about 7 weeks of life. It should be separated, and the rectum and anal canal is opened in the perineum separately, and from urogenital sinus, the vesicle, there is urinary bladder, ureter is also developed from the separate sinus. So in 7 weeks of intrauterine life, it should be separated. The cloaca should be separated into two division like urogenital sinus and the caudal, most caudal division from where rectal and anal canal is developed. So, uh, if any arrest of division of cloaca. If the cloaca is not divided properly in anterior urogenital sinus and posterior anal canal rectum, at that time these developmental anomalies may lead to anorectal malformation. Some classification of anorectal and cloacal malformation. The term anorectal malformation has come to represent a broad spectrum of abnormalities involving the termination of the hindgut. So it is important about hindgut, and pediatric surgeons and anatomists have tried to classify anorectal malformation in a rational way. The terms high and low have been the most widely accepted concept. So high and low. So the classification is also different in case of male and female. That is, in shortly, we can classify the anorectal malformation mm, high and low variety, low variety and high variety. It is easy to say that is when the anus is not perforated in the perineal skin, but rather it is just stopped here in the just uh, level of perineum or skin. It is low variety. But when it is opened in the urethra or urinary bladder, because of its high insertion, it is called high variety. So in every time you remember that in case of high variety, there may be associated fistula, and these fistulas, anorectal, rectovesical, or rectourethral fistula are more common in case of male because the urethra and urinary bladder is uh, very much close, closely situated in case of male, that is rectum posteriorly, and just in front it is urethra and urinary bladder. That's why male are more preponderant to develop rectourethral fistula. But in case of female, in between rectum and bladder, there will be vaginal tract, and there will be the vaginal orifice situated in between the urinary and rectal uh, compartments. And that's why rectum cannot go close to the bladder, rather it may involve the vaginal opening and may create a rectovaginal fistula. So in case of female, rectovaginal fistula is more common, and in case of male, rectourethral fistula is more common in case of high variety. Remember, it is high variety. But in case of low variety, when the anal canal is just is going to perforate but not perforate, just a little bit above the perineal skin. And this low variety, mm, low variety RM is easy to it is easily to manage by mm, doing anoplasty easily. But in case of high variety, it is challenging to manage by a pediatric surgeon. So these are some time you can shortly say it is high variety and low variety. High variety and low variety. How can you assess a high variety fish, high variety ARM, that is anorectal malformation, and low variety ARM? We can assess it uh, by sees the perineum, that is perineal examination is more important to diagnose whether it is high variety or low variety, and also history of passing meconium through the urethra in case of male baby. It is pathognomonic features diagnosis of high variety of ARM in case of male. So rectovestibular fistula is the most common defect seen in girls, where the rectum opens in the vestibule, which is the space between the hymen and the perineal skin. Most have a good sacrum and anasphincteric mechanism. Rectourethral fistula is the most common defect in males. There are two types: bulbar, where the urethra opens in the lower posterior urethra, and prostatic fistula opens higher within the prostatic urethra. So the latter has a higher incidence of sacral dysplasia and poor anal sphincteric muscle. This is a uh, picture showing external appearance of female infant with imperfect anus and vestibular fistula. This is also an external appearance of male infant with imperfect anus and perineal fistula. It is here, it is present a meconium stained size. This is a aperture and it is very stenosed and narrowed. It is called perineal fistula and it is low variety. So how can you uh, uh, diagnose a case of anorectal malformation by uh, radiograph? The radiographic image is only you can diagnose anorectal malformation by seeing the X-ray films. What is X-ray? That is invertogram X-ray. Invertogram means invert position. Here it is in invert position. You can take an X-ray film of abdomen and you can um, see the intestinal, uh, the gas shadow of the loop, the distal loop of the intestine where it is end. And there is a marker in the perineal skin where the proposed anal orifice should be located. And the distance between the proposed anal orifice and the blind ended loop of the rectum, this is important. So if it is very near to the proposed anal orifice, it is low variety, and if it is high enough from the proposed anal orifice, it is high variety. So by the radiological features in bartogram, you can diagnose rectal malformation. But sometimes in bartogram, uh, taking in bartogram X-ray is sometimes difficult in case of neonate, and it may create some problem to neonate. And the most common problem is aspiration of the gastric content and may create aspiration pneumonia. And to avoid these types of complication, we can do uh, prone cross-table lateral view of the abdominal X-ray. The position is like this, frog position, by taking or keeping a sandbag below the chest wall, and a baby should be kept on prone cross table prone view, prone position, that is jackknife position, and you can take an X-ray, and it may um, avoid some complication which is common in vertebral X-ray. So our idea is to diagnose the high and low variety of ARM to see the blind-ended loop of the intestine, it is rectum, and the proposed anal orifice. The distance between these two segment is important. And also another problem is here, that is intestinal obstruction is only clinical features of anorectal malformation. So thank you for today, and I end my lecture. Next day I will discuss the later portion or remaining portion of the anorectal malformation. Thank you.